Well, good afternoon, everybody. I want to welcome you to our Lown Group webinar series. And today we are delighted to have Dr. Carolyn Bernstein, who is a board certified neurologist, also board certified in headache medicine, talking to us about migraines. Dr. Bernstein did her training at Boston City Hospital and New England Medical Center, and she's the author of The Migraine Brain and has co-edited some other textbooks and won multiple awards for her teaching and for her humanism. And I think you'll see why shortly. She's a world-known, renowned expert in migraine headaches, and she's going to share with us her approach to treating migraines. So welcome, Carrie. We're thrilled to have you here today.
Thank you so much. I'm honored to be here. Let me get started. So I'm going to talk about migraines, headaches, and brain health. And the first question I think really is, what is a migraine and how is it different from a headache? Migraine is actually considered a disease, so it's not just a headache. There are other components that are part of the migraine. I'm going to define them for you, talk a little bit about that difference, describe a common kind of headache that many people actually experience, go through some of the treatments, and hopefully educate you on brain health as well. So those in the crowd who have migraines, I think, can probably relate to this picture. So here's a little table for you all about migraine versus tension type headache. Tension type headache, the old name for it, is hat band headache. There were some great names for different kinds of headaches that are no longer used, but I think that's very expressive because it really, a tension headache is a band of pain that goes around the head. And if there weren't a pandemic and we were all sitting together, I'd ask you to raise your hand if you ever had a band headache or a tension type headache. And I'm going to guess that almost every hand in the audience would go up because these are really common. This kind of headache can be pressing, it can be pounding. Usually there's only one accompanying feature, and I'll explain that to you in a minute, but you need at least 10 to make the diagnosis. It's less severe. It's the kind of headache that we all get when we've been sitting in front of Zoom all day or trying to make our lives work during the pandemic or not during the pandemic. We're tired, maybe we're a little bit hungry, but there's nothing focal or really highly concerning about it. On the other hand, a migraine is a one-sided headache. So this is kind of interesting. The word comes from the Greek word hemicrania, right? Which means half the head. So if you look at the migraine, migrania, you can see the etiology of the word. And there are actually descriptions that are as old as 2,000 years in Greek literature of people with headaches that fit with this diagnosis. The pain technically has to be throbbing. Really different than that kind of pressing or pounding pain that is a tension type headache. The intensity has to be moderate to severe. And in the world of headache, we use that 1 to 10 scale, right? With 1 being kind of a mild, just enough so that you know it's there, and 10 being so bad that you're ready to, go to the emergency room that you can barely stand it. So moderate to severe, somewhere between a level 6 and a level 10. The headache has to last between 4 and 72 hours. If it's more than 72 hours, it's called a migraine status or status migrainosus. It basically means the migraine has just stuck. And you either have to have sound and light sensitivity, which we call photo, light, and phono, sound sensitivity, photophobia, phonophobia, if you've ever heard those words, or you have to have nausea or vomiting. I personally have never seen anybody who's vomiting who wasn't nauseous, but that's the way the criteria are set up. You have to have at least 5 events in order to make the diagnosis. Now, I mentioned a minute ago that there are a lot of subtypes of migraines, and one type that you may have heard of is migraine with aura. It turns out that having an aura is much less frequent. It's only about 1 out of every 5 headaches, so it's not nearly as common. And it does have some implications. So we're going to come back to that. People can have vertiginous migraines. Some of you may have experienced those. the headache, as well as that spinning sensation, like the world is going around, a horrible sensation. There are hemiplegic migraines, which can look like a stroke, where you can't move half your body. There are basilar migraines, so there are lots and lots of different types. But the main type, the most common type, is this one-sided throbbing headache with the either sound and light sensitivity and or nausea or vomiting. So why is this important? Because these are specific criteria that have been set to make the diagnosis. This is a clinical diagnosis. There's no blood test we can do to prove it. So when we think about headaches, we think about what are called red flags, and that term applies to lots of different things in medicine. A red flag, right? You're waving the red flag. It means time out, stop and think, get worried. Could there be something else going on? Most of the time, a migraine headache is what's called a primary headache. That means it's not caused by something else. If somebody had new or focal features with their headache, I've had a typical migraine like I just described to you a minute ago for 5 years, but all of a sudden my left body is numb and it's persisting and it's getting worse. That would be really concerning. First headache that you've ever had, worst headache that you've ever had, those are things where you want to let your healthcare provider know what's going on. If you're a person who never had a headache before and all of a sudden you've got one, just want to make sure nothing else is causing it. And then, as I alluded to a minute ago, a headache that's new or different. Well, my usual headaches are on one side, they're throbbing, I get sound and light sensitivity, but all of a sudden, my head feels different. It changes if I'm lying down or sitting up, and I'm having projectile vomiting. I'm throwing up so much that it's, sorry to be frank, hitting the wall. That would be really concerning to the point where you'd want to contact your healthcare provider. For us as neurologists and headache specialists seeing patients, is there something on the neurologic exam that's abnormal? Does somebody have an abnormal reflex? Is there something going on when you look at the back of the eye? That's called the fundoscopic examination. Somebody weaker on one side than the other. So are there any kind of clues that might point to a different cause for the headache? The International Headache Classification Guide is 147 pages. And that's how many different types of headaches there are. There are lots and lots and lots of categories. So as a headache specialist, when I'm seeing you, I'm running through my head, could it be anything else? What's the correct diagnosis? And if I don't know, I want to be able to tell you that and do tests that might exclude other possibilities. Are there other contributors like COVID? What a beast. You knew we weren't going to get through a talk without mentioning it, right? It can look like just about anything. So now we think about with Omicron, mild cold symptoms, a runny nose, a sore throat, change in voice, some muscle aching. Those can be things that are really pretty non-specific. It can also trigger a new and different headache. So there have been a couple of people I've seen or heard from who've had a new and different headache, and it has turned out to be COVID. So again, if you get something that you haven't had before, you want to let your healthcare provider know. So last note here, don't self-diagnose. Dr. Google is not your friend, especially at 3 in the morning, right? If you start looking things up, you can scare yourself into outer space. I know that because I've done it. So I recommend having somebody who's really trusted, that you can rely on, who knows about healthcare, who is a healthcare professional, your doctor, your nurse practitioner, whoever takes care of you. So migraine pathophysiology is really interesting. I'm going to show you one of the tools that I keep here. This is my home office. Welcome to COVID. I often use this little string of mala beads. It's really useful for being a DNA kind of device, right? So DNA is pairs of nucleic acids that code for pretty much everything that happens in our bodies. And if you think of these different colored beads, maybe here's the gene for the pain part of migraine. This red one is the gene for visual aura. Here's the nausea and vomiting gene. Everything's all wound up together, okay, most of the time within the cells, within the neurons, and something may trigger this. It could be for a woman getting your menstrual period. It could be having a glass of wine, or poor sleep. We're going to come back to different possibilities, but it's some kind of inflammatory response. The DNA will unwind, messenger RNA will come in and kind of take a picture of the abnormal genes, send it into the mitochondria, the part of the cells that are responsible for making proteins and packing them up. And a whole series of events will then happen. Something, I'm sorry here, go back. A wave of what's called cortical spreading depression. So I want you to think of that as a wave coming through the ocean, about to crash on the shore. Think of something like that going on in the brain of somebody who's having migraines. There's a lot of different cellular messages that begin to take place. Some of that wave will spill into part of the brain called the hypothalamus, where the nausea and vomiting center sits. Some of it may spill into part of the brain that controls vision, the retina, where light sensitivity will get triggered, sound sensitivity may get triggered, and it all eventually ends up in a nerve called the trigeminal nerve. I'm showing you on my face. It looks almost like a hand splayed out across the face. The top branch up here is the part that often gets triggered with migraine, which is why if I said to somebody with migraine, point to where it starts, they're either going to point to their temple, the back of their eye, or over their eye. Not everybody, but most people. So it's a whole, I want you to think of it as that DNA opening up, picture being taken, changes within cells, and then this whole wave of events that takes place. So one of these inflammatory neuropeptides is called calcitonin gene-related peptide. And we know now that that's a really important trigger and activator for migraines. And again, we're going to come back to that because some of these really cool new drugs that are so effective, they work on CGRP. You don't have to remember the whole name. So just to give you a little picture, I have this really cool graphic of the brain. Oftentimes the activity will start in the back and move forward. It will propagate. Remember, I was telling you this wave of cortical spreading depression. Right about here is where that hypothalamus is, where the nausea and vomiting center sits. Some of it will spill in there. So just to orient you, somebody's nose would be right here. I'm kind of drawing it out. Their eye would be maybe up here. So spills down and out, and then eventually ends up right back here where the trigeminal nerve is in part of the brain called the brainstem. And that's the part that actually controls the pain. Really interesting. You can have a migraine without necessarily having a headache, which is why we now call it migraine disease. We don't call it just a migraine headache, as opposed to what we started out with, the kind of headache that we all experience from time to time, or most of us, tension type headache, really different. With that, it's more muscular. All these different biological events in the brain are not taking place in the same way. So once that wave of cortical depression starts, we are off to the races, and all these different things start to happen. Now, if you're a person who gets migraine, you may know that it's about to start by something called a prodrome. So it's a sense that something just isn't quite right. Some people feel really activated. A lot of people have a sense of doom. They feel tired, they feel weak. Some people are just incredibly energetic, and that can start as long as 24 hours before the actual event itself takes place. Can you interrupt it before it gets going? Yes, if you can recognize it early enough. What can trigger a migraine? So a lot of different things. Dehydration is a big one. It's going to come back to that and why it's important. But certainly drinking a lot of water, whether you have migraines or not, is key. Poor sleep, changing your sleep cycle. So even if you decide to sleep in on a Saturday or Sunday, you may wake up in the morning and realize that you've got a migraine. Stress can do it. What we call the estrogen drop theory. So for women, again, who are cycling hormonally, who have not gone through menopause, or who may be taking an oral contraceptive pill that works in a cyclic way, when the level of estrogen goes down, that can trigger a migraine. So you're getting the sense here, anything that changes the brain, the way the brain is structured, can be a trigger. There are food triggers. Chocolate can be one of them, but not for everybody. Red wine has gotten a bad name for a long time, but it turns out that any kind of alcohol can trigger migraine. Some people can drink spirits, they can't drink wine. Some people can only drink beer. Is it a myth? Is it not a myth? What you have to do, especially if you think something is a food trigger, is look every single time. You have to consistently get a migraine within 4 hours of consuming that food. So let's say that you eat aged cheese, you get a migraine, but 2 weeks later, you eat some more aged cheese because you love it and you don't get a migraine. I'd wonder about that. I hate to see people who really restrict their diets tremendously in the hopes that it will keep them from having a migraine, because they end up with poor nutrition and they're still going to get the migraine. So it takes some work to figure this out. Nothing at all can trigger a migraine. So sometimes they just happen despite people doing whatever they can do to keep themselves well. And it's important to look for triggers, to make sure that you've done everything to keep yourself in great shape in terms of headaches and in terms of wellness, but know that you may not necessarily be able to control this. So how do you make a migraine stop? I just told you a minute ago, if you can recognize what your prodrome is, or if you can recognize that the migraine is starting, you want to treat at that moment. The earlier you treat, the more likely you are to stop the events from turning into a full-blown attack. So here are some different things, drugs and non-drugs. Triptans, which some of you may have heard of. I'm going to use generic, and I'm also going to use brand names, and I don't have any affiliations. I'm not touting any one drug over another, okay? But triptans, hallmark in this class is sumatriptan. The other name for that is Imitrex. There's rizatriptan, which is Maxalt. Some of you may have heard of that. Naratriptan, which has emerged. There are 7 different drugs in that class. And what they do is they make one neuropeptide, not the one that I just mentioned, a different one. They make it able to bind more easily and stop the response. And for a lot of people, they're a very good choice. They're not necessarily great choices for people who have certain cardiac or vascular conditions. And so that would be something to think about. If you have ever had a heart attack, these wouldn't be the best choice for you necessarily, and they'd be something to talk to your doctor about. Gepants are really exciting. I know these names are ridiculous. Gepants are newer molecules. They work on that important neuropeptide I was just telling you about, the calcitonin gene-related peptide, CGRP. They're called small molecules, and what they are antagonists. So they take that CGRP that set off that whole wave of cortical spreading depression, and they kind of undo it so it stops. People use the term life-saving and life-changing about these drugs. They can be that effective. One name that you may have seen TV ads for is Ubrelvy. The other name for that's Abrogepant. Another is Nurtec, which is Rimagepant. There are several in the class. I put Serena over here for 2 reasons. Number 1, she is the spokesperson for Ubrelvy. And number 2, I think she was really gutsy to go out there and say, I have migraines. Bring some acknowledgement about an illness that is so common that is stigmatized for a lot of people who get the, oh, come on, it's just a headache response. Thank you, Serena, for helping to say, wait a minute, this is really big. I work on my treatment. I work to keep myself healthy, and I may still get a migraine. And now I'm getting a little extra cash because I'm the Ubrelvy spokesperson, whatever. So NSAIDs are drugs like ibuprofen and naproxen. Remember that I told you a minute ago that migraines are inflammatory. These drugs work against inflammation. Aspirin sometimes helps. It's an older drug. It tends to thin your blood, right? So you want to be careful not to take too much, but that can also be helpful if there's nothing else and you're starting to get a migraine. Older combinations of medication. There's one that uses a barbiturate called butalbital, caffeine, and acetaminophen, which is Tylenol. The brand name for that is Furacet. Problem with that one is it can really cause rebounds, and we try not to use it very much, but it may be the only drug that's safe for somebody to take. If you've got a great acupuncturist and you can get in the moment, that can help to break a migraine. Going to bed and just trying to sleep it off can help. Sometimes just recognizing that you're dehydrated and having some water or some herbal tea, something that's hydrating, watermelon, is extremely hydrating, probably because it's got a lot of water in it, but it also tastes good. That may help. And ginger is a folk remedy with some data to support its use for the nausea component of migraine. So we've got some really good choices here. So what about prevention? Whoops, it's better not to have a migraine at all, right? And so we've got some newer biologics that I want to tell you about. We've got biobehavioral treatments, which are things like cognitive behavioral therapy. I'm going to come back to that. We've got some of these non-pharmacologic therapies like acupuncture, craniosacral therapy, and I'm really interested in things that involve using fewer drugs for people. But overall, what's really important about prevention is what's called homeostasis. And I'm realizing I left the O out of that word, my bad, but it means keeping everything the same as much as possible. So keeping a sleep cycle that works, exercising in a way that works, eating well, drinking plenty of water, all of that is important. Just keeping your brain as happy and healthy as you can. So some of the newer biologics include these injectable monoclonal antibodies. I actually have a demo kit here because this is my home office. This is for one called galcanezumab or Emgality. It's very cool. Instead of taking a daily prevention medicine, people will inject this in their leg once a month. It has a significant impact for a lot of people, really cuts down the number of migraines. You have to take a daily medicine, and it's safe for the majority of people to use. So that's an exciting option. I define it as a kind of catch and snare mechanism. So it grabs that CGRP, that neurotransmitter that's so implicit in migraines, and it prevents it from being dispersed. When people think of monoclonal antibodies now, they think of monoclonal antibodies for COVID. This is completely different, doesn't involve your immune system at all, and generally easy for most people to tolerate. So some good options to think about, to talk to your doctor, your healthcare professional about for sure. So I've got my mantra number one. It's not your fault that you get migraines. So remember my Mala the DNA, you inherited the tendency to get migraines. And oftentimes there's somebody older in the family, a parent, a grandparent, a first-degree relative who also had migraines. In the old days, they often called them sick headaches, use different terminology. Nowadays, we understand a little bit more about migraine genetics. All you can do is manage this until we figure out how to actually do gene repair. Not there yet, but some good treatments that exist. So we've got, in terms of medicine that can be used for prevention, we've got the older drugs that have all been repurposed from other causes. So things like propranolol, an antihypertension medicine, would be one possibility. Anticonvulsants, those are drugs that are used for seizures. They also have FDA indications for migraines. Topiramate is the name of one, Topamax is the other name. Older antidepressants used at very low dose. I put amitriptyline here, another name for that's Elavil. Another name for propranolol is Inderal, just so that you've got some brand names that you might recognize. All of these drugs can be very effective, but they're not targeted in the way these injectable monoclonal antibodies are, and I'll come back to that. For people who have what's called chronic migraine, which means at least 15 days a month, ouch, of either headache or migraine, after a while it tends to sort of fuse together because it becomes so frequent. Onabotulinum toxin, which is Botox, applied in a set protocol can also be really helpful. So that's another possibility for certain patients, and it's extremely safe. I'm amazed when I'm doing Botox clinics, people have gone from those 15 or more a month to 1 or 2 migraines. So that's a huge, very dramatic response, and it's injected just 4 times a year. So kind of minimal impact on life overall. The injections are very quick. I often teach people a meditation or visualization and just get them through it. And then they're done, and it really does affect the migraine frequency. So another excellent option. So when we talk about migraine effectiveness, we tend to measure it in the decrease in number of migraine days. Okay, you went from 8 to 4. We look for at least a 50% reduction, what's called statistically significant, in the number of migraines, right? So people keep their journals, their headache journals, so that we can make sure that the drugs are working. And I'll look at those with patients and try to say, okay, well, you did get one when you got your period, you had this one, you missed a sleep for a night or something else was going on, but overall things are looking pretty good. But does that really tell the whole story? Is it just decreasing the number of migraine days? I would put forth that it's really more than that. If you have a chronic condition, any kind of chronic condition, whether it's related to how you breathe, how your heart's functioning, how your brain's functioning, just decreasing the number of actual events does not really completely describe the impact that it has on your life. There are a lot of different things that I think about when I think about what it's like for people who have migraines. There's anticipatory anxiety. Oh my gosh, when am I going to get the next one? When's it going to take me down? What if it's the day that I need to watch my child be in a school performance? Let's pretend there's no pandemic here. And when that's possible again. I've got a really important work event. What happens if I get a migraine at that time and I can't make it stop? Then there's missed days of work and family life. And those are for those of you who have migraines, you know this story. You can tell this story better than I can. My whole family went to celebrate Thanksgiving, but I had to stay home in bed because I had a migraine. It's pretty horrible when you look back on it. There are the mood changes that go along with having some kind of chronic disease or illness. I'm depressed. I don't know when migraine's going to take me down. I never feel completely well because I'm always worrying about it. And then living with constant pain is also really hard. So it's much more, I think, than just the number of days of migraine. Which is why I really am interested in these biobehavioral techniques. So cognitive behavioral therapy, CBT, is something that's been scientifically shown to decrease number of migraines, but also change how people feel about their migraines. And that's a really, really cool way of teaching your brain to work with the rest of your body and swing your attention away from pain generating areas. And so you might learn how to synchronize your breathing with your heart rate. You might learn how to change the temperature in your hands, believe it or not. These are very specific, concrete techniques. All of this stuff can be taught remotely now. We realize we can do virtual pivots for everything. MBSR stands for mindfulness-based stress reduction. And again, if I were sitting with all of you in front of me, I'd ask you to raise your hand if you've tried this or you know someone who has. This is a very cool way of learning mindfulness, learning how to stay in the present, learning how to not worry about what's coming at you in the future, often taught in a group. And then there's another kind of biobehavioral technique called acceptance and commitment therapy that I'm also really interested in. And that is also taught in a group. It's more about accepting the fact that you have the migraines. How can you make your life as full as possible? And then finally, meditation. In the moment, it can swing your brain away from the fact that you're having the migraines. It can be really helpful. So I want to talk about stroke risk a little bit. I told you before, 1 out of every 5 people may get an aura with a migraine. The most common kind is the glowing zigzag, the hole in your vision. People sometimes will start to talk gibberish before they get a migraine. They may get tingly on one side or the other. The stroke risk overall for all comers in the basic migraine demographic is really low if you don't have other contributing factors. So for an otherwise well person, it's about 1 in 10,000, which is a really tiny risk. If you have migraine with aura, that risk doubles, but it's still really low. But if you add an estrogen-containing oral contraceptive, for whatever reason you might be using it for, that risk does go up. And that does not apply to HRT, which is hormone replacement therapy, which is a much lower dose of estrogen. So a really big difference. This is a question I get asked a lot. The fact that I have migraines, does that raise my stroke risk? It may raise it a tiny bit, more so if you have aura. What can I do about it? independent risk factors for stroke, right? Like high cholesterol, hypertension, being a smoker, all of those things. You want to modify everything you can to keep yourself well, regardless of whether or not you have aura, right? None of us want to have a stroke. But those are the things that you can do. There's no evidence that if you have aura that you should be on blood thinners or anything else like that. So there is a tiny risk. There may be a tiny increased risk as well for people who don't have migraine with aura, but again, it's very, very small. So I want to reassure you. One thing I meant to say a minute ago is the reason we think that the aura may be more likely to generate a slightly higher stroke risk is that we think that people who have migraine with aura may have slightly stiffer blood vessels, so that platelets and other blood components may bang into the side and form little clots, which can then fly up to the brain. Risk is very low. If it's a risk-benefit situation, if you needed to be on an estrogen-containing oral contraceptive, it's a great discussion to have with your neurologist, headache doctor, OBGYN doctor, cardiologist, primary care provider, whomever it might be. So what can you do to minimize that stroke risk if you have migraine? What can you do to keep your brain healthy? Keeping your brain healthy, keeping your heart healthy. Those are the things that you can do. So think about your life. Think about things. If you're a migraine person, what can you modify and what can't you modify? You can change how you exercise, how you sleep, how you eat, how you hydrate. You can work on your mood and how you deal with anxiety. You can address those cardiovascular risk factors I mentioned a minute ago, like increased cholesterol or high blood pressure. What can't you change? Those genes. You can't change them. We can't repair them yet. There may well be a day that we can, and then I would be out of a job, and you know what? That would be a very good thing. But and I would find something else to do, but I'd be really happy if nobody ever got another migraine. So let's talk about the things that we can modify. Mantra number 2, every act of wellness counts. So I know this sounds kind of simplistic, but everything that you do to take care of yourself is better than if you didn't do it, no matter how small it is. So let's start with exercise. It is one of the most potent anti-inflammatories that we have. It decreases your stress level, it improves your sleep, helps your mood, and people ask me this question all the time: what can I do to decrease my risk of developing dementia? I had a family member who had dementia. What can I do? The one proven thing is to be physically active. So you can tell this is super important, finding ways to exercise, and they have to be fun and they have to be achievable. Here we have somebody in tree pose doing some yoga. And so I think with exercise, like a lot of things, break it up. There's really good research now that tells us that even tiny chunks, 10 minutes in the morning, 10 minutes in the evening, make a big difference. Get outside. If you have a break for lunch, go for a walk. 10 minutes might not be enough to go for a run, but 20 minutes might let you run a mile and come back and get on with whatever you're using. An elliptical machine, put on some music and dance. Anything where you can get your heart rate up and bring it back down. What's called high intensity interval training is a really efficient way to train your heart, improve your overall blood flow, help to decrease migraines, and make you feel better. Nutrition. I mentioned a minute ago, no good science about a migraine diet. The absolute, you have to avoid cheese, chocolate, red wine may be true for some, but not everybody. Some things may just not be as healthy, but they're okay as an occasional treat. My favorite nutritionist says, people ask her questions about diet, and she says, they're amazed when I tell them I like to eat chocolate cake. You know, all things in moderation really works. But basically, what we want people to do is eat the Mediterranean diet. So eat a diet that's really heavy in plant-based foods, Lots of colors. I put here 5 a day. I try to achieve that. I will tell you, I don't know that I do every day, but I do my best. I eat pomegranate seeds every morning. They're a superfood. Berries are really good for you. The brighter the color, the better the food, unless it's an artificial color. Okay. So lean protein, fish, certain kinds of fish can be really helpful. Food has to taste good, and that's really important. If it tastes disgusting, I wouldn't eat it. I don't want you to eat it. So find things that taste good, that are really healthy, and give yourself an occasional treat. Hydration is super important. One of my colleagues, when we were able to do some workshops, I don't want to say live because we're all alive, but we were able to do some in-person workshops. She would serve water. She'd come in early and she'd dump in chunks of watermelon or lime or grapes, and it just tasted that much better, was more refreshing. So in a perfect world, we'd all get up and make ourselves a big pitcher of spa water in the morning. You know, if you do it once a week, that's better than not doing it at all. How do you drink when you're wearing a mask all day? Get a straw that's got a bend, get a glass straw so you can reuse it. It's got a bend in the end. Stick it underneath your mask so you don't even have to pull your mask down if you have to work in a place with a lot of other people around you. I had a professor when I was in training. He used the somewhat crass term of instant person syndrome, but it was a good enough term that I've never forgotten it. Add water and stir. When you're really dehydrated and all of a sudden you have enough water to drink, everything is going to feel better. So drink that water as much as you can think of, and try to just make it a mission every day not to let yourself get thirsty. Sleep, back to homeostasis, spelled correctly here. Regular bedtime. We all know about decreasing nighttime screens. You know, it's really hard these days. You do the best you can, but try to be active during the day. I want to very quickly, I know I want to take some questions and I'm running a little bit low on time, but I want to give you a quick demonstration of something called progressive relaxation. So you can look that up if you want after we finish. That's a technique that really can be helpful if you're trying to fall asleep and you can't let yourself just sink into the bed. Lie on your back, put your arms down by your side, stretch your legs out, and start with your feet. And you're going to go from your toes to your ankles, to your knees, your hips, your shoulders, and finally up to the top of your head. Try to tighten your muscles, starting at the base of your body, and then relax them after a few seconds. Then move to your knees, your legs. As you move up your body, you're going to tighten and relax. It's kind of distracting, boring, and lets you really sink into it. Most of the time when people try this, by the end of it, they're asleep. So give it a try. You can also get a sleep consult. There are sleep behavioral specialists who can teach you more sophisticated techniques than that can also be super helpful. So stress, well, there is a pandemic, so let's face it, we're all living in a stressful time, but I think trying to mitigate that and really thinking kind of internally, what's making me feel stressed and what can I do about it is important. So we talked about some of these biobehavioral techniques. I'm going to teach you a second one in a minute, but there's what's called the counting meditation. You're out for a walk or out for a run, try this. Count your steps or count your breaths up to 100 and then go back down. So up and down and up and down. It's an actual kind of meditation that doesn't require you to sit on the floor with your legs crossed, but lets you do something where your brain is only focusing on one thing. So maybe instead of listening to a podcast when you take a walk, try a counting meditation. Knitting has actually been shown, believe it or not, scientifically, to let your brain kind of relax, kind of unhook from anxiety. I think because it's a repetitive motion. Art therapy, there's some really good science about that, decreasing stress. Putting on music when you're at home, whether you're cooking, cleaning, talking to your family, doing whatever it is that you do, having some kind of ambient background music can also help to decrease stress levels. So cardiac coherent breathing is a really interesting kind of breathing where you breathe 6 times a minute. And what you do is, I want you to all try this afterwards. You breathe in for 6 seconds and out for 6 seconds. So when we finish with this meeting, if you close your eyes and you sit there, try breathing in and then breathing out. Try doing it even for 3 slow breaths. What a lot of people realize is that they don't actually fill their lungs all the way. And after a few breaths, I'm pointing to my shoulders to show you, people start to bring their shoulders up. They really open up their whole chest cavity and allow themselves to take some deep breaths. Breathing has become a metaphor for many things during this pandemic. Cardiac coherent breathing, I promise you, it will make you feel better. So what happens when we're stressed? We activate lots of different kinds of hormones in our brain. They can trigger migraines. They can trigger other kinds of inflammatory conditions. What's a really good way to get rid of stress? The breathing that I just showed you, some of those other techniques, and try to be physically active in some way that's fun. How can we keep our brains healthy, whether we have migraines or not? What are ways that we can prevent our brains from being more likely to develop some kind of memory issues? So exercise, I think I've blown this one up, but also engagement, doing things that are new, that are stimulating, that are different, learning a new language, playing a game of Scrabble, doing a crossword puzzle, reading something really that's outside of your wheelhouse, that's a little bit different, just things that make you think in a different way, having a discussion about that. Those are all things that can help us keep our brains as healthy as possible. So here are the key points from my talk that I want you to take away, and I hope you do. I hope I've explained them well. Migraine's treatable, but not curable. It's really different than other types of headaches. It's migraine disease. Always important to have a discussion with your primary healthcare provider. There are lots of good treatments. There are these really cool new targeted biologics, other treatments that may work for you. There's a very slight increase in stroke risk, in particular for migraine with aura. You can own your brain health, and anything that you can do to improve your own wellness is better than nothing. Anything you do, give yourself credit for that. So I want to thank you for your attention.
Thank you, Carrie. That was really a spectacular overview of migraines. I have learned a lot, and there are a bazillion questions here in the chat. So first, I just want to say that I love that there is this reinforcement of the things that we've been saying in all of these webinars. And from a heart health standpoint, it's the same for neurologic health, isn't it? Just stress reduction, sleep, healthy diet. We heard about cognitive behavioral therapy, anti-inflammation, and all these things can also help with migraine prevention. So yay. There's a few questions here about specific types of migraines, ocular, vestibular, sinus migraines. Can you talk a little bit about those subtypes?
I will. So ocular migraines, that's a term that some people use when they just get those visual symptoms, like they might see what some people will call an aura. Aura is probably, there's so much verbiage in neurology, and a lot of it is just, it's hard to wrap your head around it, no pun intended. But an ocular migraine may be, you see a glowing zigzag, right? Or you see a hole in your vision and it gets bigger and bigger and then it goes away, but you never get a headache. Oftentimes, that's a sign that the migraines are beginning to burn out. People tend to get that more as they get older. So remember those genes that I showed you on my string of beads. So the pain modulating part of the migraine may be just starting to wear out. And what's left is just the aura, which people will call an ocular migraine or migraine equivalent. So those are different terms that people use. Vestibular migraines are the ones that they're all horrible, right? Let's just start with that as the baseline. Those are the ones where people will start to spin. The world will start to spin around them. They'll feel like they're on a boat. They'll feel like things are rocking. Those can be very, very difficult for people. Here's something interesting about vertigo. Another name for that's vertiginous migraine. When you have that feeling, what do? You get really still because it's so scary to move. The stiller you get, the longer it will take to resolve. So ironically, what you want to do is sit down somewhere where you're safe or hold on to something, but slowly move your head from one side to the other. And don't hold still because it doesn't let your brain recover. If you're throwing up, obviously you can't do this. But if you have vestibular migraines, it's another good reason to find something safe and active that will help you recover. I ran a spin class for patients with migraines a couple of years ago. And it was really interesting. I thought spinning would be really safe because everybody would be sitting on the bike and they could hold on. And somebody started to get a vertiginous migraine, and she slowed down the speed that she was moving her legs. And I jumped on the bike next to her, and she actually kept going, and the migraine disappeared by the end of it. Another thing, people who say, I get a migraine when I start to run or walk, if you can get through the beginning, I know it sounds kind of sadistic, it will often quiet down. So ocular migraines, vestibular migraines, remind me what the third kind was?
Sinus?
Yeah, so a sinus migraine isn't really a migraine. A true sinus headache, you have to have evidence of sinus disease, either by the ENT doctor puts a scope up your nose and takes a look, or you have a CAT scan of your sinuses and there's junk in the sinuses, or you have green goo coming out of your nose, to be very technical, and otherwise it's often a migraine. So the pain can manifest, we talked about where it can localize, the temples, over the eye, behind the eye, but it can also be in the sinus areas below or above the eye. That's probably a migraine. So if it's throbbing and it's painful and it repeats like that, you don't need antibiotics. You need one of those acute medicines that I talked about.
Got it. Thank you.
Can I just jump in here with a quick follow-up on that, Carrie? This is such a great discussion, but I think from reading the chat, there's a number of people that are having trouble just seeing how you would incorporate in some of these lifestyle things to your regimen, especially with prevention. And that example with the spin bike, I think was a good one, but just in terms of maybe the breathing or seeking out CBT, like what's your approach to kind of, integrate those things in?
Yeah, so, for all of us, right, we spend a lot of time, especially these days, sitting in a chair, staring at a computer. Between an event, between a meeting, for those of us, let's say for me, seeing patients sitting here, I might take 2 minutes between patients and I'll do 10 cardiac coherent breaths. And I'll feel so much better by the end. Or I might say, oh, look at that. I've got 5 minutes. I'm going to stand up and I'm going to do 2 yoga poses. Little chunks, chunk it out and get it in. Don't just sit. So anything that you can do is great. Sitting on the spin bike. So if you're somebody who's unsteady, or maybe you're just starting to become active, you don't have to go out and run a marathon. You could sit on a bike. You could maybe, not right now, but maybe things hopefully will look different in 4 weeks. You could go to the Y and you could swim. You could walk in the water. Just walking back and forth is really just a great activity, but you can do just the tiniest thing. And if you've got little kids at home, maybe you put music on and everybody dances. Maybe you play follow the leader and you skip around the house. I know it sounds stupid, but again, what are you doing? You're getting your heart up, you're getting your blood flowing, you're doing something active better than sitting. So tiny, tiny things. If I'm feeling really tense about something, I will take a few minutes and I will do a little bit of that breathing. There's something called alternate nostril breathing that I didn't put in the talk that's also relaxing. So you take your index finger, put it right, this is called your third eye, put it here, block one side of your nose, take a breath in the other, switch back and forth very slowly. It's another kind of calming anti-anxiety breathing that can really work. Then there's a third kind that I think is completely disgusting, but I'm going to tell you what it is. It's called skull scraping. And so you blow your nose before you do this. And probably right now you don't want to be around anybody else, right? So blow your nose and then you forcibly snort breath through your nose. It does slow everything down. It's just kind of yucky. So that one is not on my repertoire. But the cardiac coherent breathing, I have taught that to more patients, colleagues, medical students, doctors in training than I could ever count. And everybody feels better. You can take 2 minutes and you can do 10 breaths and you will feel better by the end of it.
That's wonderful. And I think there also is some overlap with also seeing blood pressures lower too when you take on those kind of meditative breathing, right? So it really does affect your cardiovascular system in multiple ways.
You can slow your heart rate down as well. So excellent point.
There's a question about dysautonomia. Oh, sorry, I jumped right over you, Brian, but I'm going to keep talking. Dara and I do have a number of patients that have POTS or dysautonomia, where that relaxation kind of and feedback of the volume in your body is maybe a little bit different. So some of these patients might be joining. Do you have any words or recommendations or things you've seen in that patient population?
So really great question, because there's a lot of overlap between dysautonomia and migraine, right? And so, what do we want our patients to do first? We want them to try to expand their volume, but there are medications that can help as well. It's so debilitating to feel that lightheaded every time you stand up or have other symptoms of dysautonomia, but trying to find some way. That might be a person who would really benefit from sitting on a stationary bike, let's say, and just moving their legs, but having something to hold on to, or maybe even slower than that, but trying to find a way to be active and safe at the same time.
Yeah, I think that's great advice. Have you seen a clear trigger in that group for migraines related to activity, or any different recommendations?
So the people who have dysautonomia and migraines, I am not recalling any literature that supports that a bad spell of dysautonomia can trigger a migraine, but I have seen the converse. So people are stuck in a horrible migraine, their dysautonomic symptoms can get worse. And sometimes some of the medication that's used for dysautonomia can actually worsen the migraine. So it's a fine balance. And it's a nice example of when it's really good to have your doctors working collaboratively to treat you as best they can.
Carrie, thank you so much. What a tour de force. And I think your approach, the whole notion of an integrative approach to any kind of disease process or symptom process, it's a little overwhelming how complicated this can be. And I can see from the questions, there's a lot of personal issues that people are dealing with. And you've spoken about such a journey through a kind of a therapeutic, diagnostic, and then coaching through this. So it's not just the diagnosis, it's the therapy and the coaching. It's really challenging, I would imagine, in this current era of seeing patients in a very short period of time. How long does it take you to get, how many visits does it take someone to get onto a program where they feel that they can manage this? And I love the notion of it's really hard to cure. So the success is when you're managing it. I think it's probably quite intimidating for a lot of primary care physicians because of the newer therapies. So I'll just leave it there. Thank you.
So if I may, I would say that primary care doctors are amazing, and they have so much that they have to do with every single visit. These drugs are changing really quickly. There's a whole new category that's still at the research level, so there's more options. I don't think I've ever said to a patient, I have nothing left for you. And I would never say that, because there's always going to be something else. But I see it really, I like the idea of thinking about it as a journey. You really want to have a headache specialist or a doctor that you can work with, because it's a long process. And I think both the physician and the person with migraines have to be able to work together really well. And it does take a fair amount of time. You really need to think through all these different pieces that I've talked about: the nutrition, the sleep, the exercise, the overall wellness. What else is going on? I had another professor, not the one who talked about the instant person syndrome, but another professor who used to talk about everybody's ecology. And I've always loved that term. What makes you you? What are the factors that bring you where you are? So do you have some high blood pressure? Do you have a family tendency to heart disease? Have you inherited migraines? How does all of that play together? What can we do that's synergistic, that's going to make you better on all fronts? That's the goal. And that's really where having a treatment plan and a team who can really collaboratively approach it is going to be so helpful in your overall wellness.
Great. Have you seen people who have, there's a question about migraine breaching and adult onset migraines, so somebody who doesn't have migraines till later in life?
So unfortunately, that can happen. It's not that common. Most of the time, migraines show up. They're more common in women than men. There's a 3-to-1 preponderance, and they usually show up in older teenagers and young women in their 20s, right around the time of puberty and post-puberty. There's a myth that they always disappear with menopause. Nope, it's not true. 40% of people with migraine, unfortunately, continue to have migraines, but sometimes they will actually show up postmenopausally or even later. And, that is that whole theory about the estrogen drop. If hormones are not cycling and fluctuating anymore, why are people, women in particular, suddenly manifesting migraines? I think it really speaks to the fact that women's brains are different. And one of my colleagues who is a basic science migraine researcher did some really interesting imaging studies looking at MRIs, so pictures of the brain. This is a research technique. This isn't somebody that people with migraines need to have. But what she was able to demonstrate is that there are some changes in the thickness of the brain in older women who have migraines compared to older women who don't have migraines. So what does that say? It doesn't raise your risk of anything bad. It just demonstrates the fact that the brain is somewhat different, that there's a kind of intrinsic stamp, right, that's put on the brain at birth for a female compared to a male. And so it may be that those genes that we talked about are kind of quiet, and something changes later in life, and all of a sudden they begin to fire and they begin to activate.
Interesting. There was also an interesting question in the chat about someone who had surgery in the neck that affected the blood vessel drainage of the brain and triggered migraines. Is that something you've seen as well? And is there any way to approach that?
Yeah, that's just a really tough one. Those would be secondary headaches, right? So we talked about primary, which are just coming from the gene problem, versus secondary, which are after some kind of brain event. And there may be a bunch of different specific treatments that might help with the headaches, but I would approach it probably a little different than somebody who fits the basic migraine criteria.
Got it. Okay. Thank you. And then I know we're running close to the end here, but a couple of questions about triggers such as changes in barometric pressure, fluorescent lights. Any thoughts about these and ways to deal with Mother Nature here?
Yeah, Mother Nature's a beast, and getting more beastly all the time. There actually, one interesting thing that you can do, so there's going to be a big storm in Boston, right, on Friday night, and we're going to get some snow. If you have migraines that night, you can try taking 25 milligrams of Benadryl, if that's safe for you to take, of diphenhydramine. Sometimes taking an antihistamine when the weather is about to change like that can block that whole process. There's actually one drug that's sometimes used for migraines called cyproheptadine that can also help to decrease migraines. It's used more in kids than adults, but it can be very effective. So that trick, what may happen, not proven yet, is that the lining over the brain for all of us, which is called the dura, it's actually called the dura mater, which is Latin for tough mother, a little bit of a sexist term, but I won't go there. The dura may thicken with the atmospheric pressure changes, and it may press on some of these areas that can trigger that whole gene change and set off a migraine. So that's something that's being postulated. It's a little bit tricky to prove it, but there's some interesting research studies looking at it. So trying an antihistamine may help. Another thing, if you notice it every time, it could be that using the medicine for altitude sickness, which is called acetazolamide or Diamox, it's a brain diuretic. So it takes a little bit of the fluid that bathes the brain and protects it, kind of pulls it off in a safe way, just a very small amount. And if you were somebody who got a terrible migraine with every storm, that might be something that I would prescribe for you. So that could definitely help for the weather-related migraines.
So interesting. So it sounds like there's things you would do on a daily basis in terms of wellness and keeping things stable, things you might do if you sense one coming on with that prodrome to kind of abort it, if you will, and then things you would do once it's full blown to treat. And this might fall into the category of preventive, anticipatory, right? To cut it off before it becomes a full blown. So interesting.
Just it.
Wow. Dr. Bilchik, did you have some closing
Yeah,
words?
just a quick question. You did talk a little bit about Botox and also, again, a preventive strategy. Is that for everyone? How what percentage of patients respond to that, and how is that administered?
So it's only approved and only evidence for people who fit into that chronic migraine category. So you have to have a lot of migraines to be a Botox candidate. For me, I treat people twice with the Botox. So it's the injections in this set paradigm, separated by 3 months. And if they don't have at least a 50% reduction, I figure that they're not going to respond. So every single patient now that I'm treating with Botox responds, and people have gone from 15 a month to 2 a month. And, it would be great if they went to 0, but 2 a month from from 15 or more is a tremendous improvement. So it decreases the release of inflammatory neuropeptides, including CGRP, something called substance P, and other things that can contribute to how the migraine propagates through the brain. So it can be super effective.
Amazing. Okay, cool. I'm afraid we're out of time, and there are some questions we didn't get to, so I apologize to those of you who we didn't get to answer your questions. But Carrie, I just want to thank you so much for sharing your expertise with us. I think you've reached far and wide today, and I know that I personally learned so much about preventing migraines. And I want to thank all the audience for participating and joining and asking such good questions. We're actually going to be back again a week from today with another webinar with Erin Murray, who is a nutrition coach. So that should be a lot of fun. But have a great afternoon, everyone, and take care of your brains.